species of fungi on Australia's east coast. He has a particular interest in psilocybin and other psychoactive species, and is the secretary of the Australian Psychedelic Society. He is interested in the potential benefits of psychedelics and has a passion for harm reduction and advocacy. Symon's academic background is in medicine and psychiatry. Welcome, Symon. Thanks. Micha Lerner has extensive experience in drug and alcohol rehabilitation, working for both private and public practices, as well as establishing his own clinic. Micha has a Master's of Arts in Psychology and a Bachelor of Science, or Social Science Honours in Psychology from Bond University, and a Bachelor of Arts in Behavioural Science and Communication from the College of Management Academic Studies in Tel Aviv. Micha was head psychologist at the Sanctuary between 2015 and 2018, and has worked at a private drug and alcohol treatment service, the Bay Retreat, and provided psychological services to the Gold Coast Drug Council. Micha has a keen interest in the effects of drugs and alcohol on the brain, particularly psychedelic drugs, and has lectured in psychopharmacology at Bond University and has research on the subject published in prestigious medical journals. We have Martin Williams. He is the executive director and co-founder of the Psychedelic Research in Science and Medicine, research fellow in psychology at Swinburne University, and at the Turner Institute of Brain and Mental Health at Monash University. Martin is the founding member of Entheogenesis Australis, an educational charity focused on the historical use and societal impacts of medicinal plants and chemicals. Martin is the co-lead on the St Vincent's Hospital Melbourne Phase 2 trial of psilocybin-assisted therapy for depression and anxiety associated with terminal illness, and co-investigator on the upcoming Melbourne multi-institutional psilocybin trial for treatment-resistant depression and Edith Cowan University MDMA trial for PTSD. It's kind of mouthful. And then finally we have Professor James Bennett-Levy. He was a professor at University of Sydney for 15 years and has recently moved to Southern Cross University, where he is the chief investigator on a psychedelic-assisted therapy clinical trial and is developing psychedelic-assisted therapy-based research. He is one of the world's most published researchers on therapist training, with groundbreaking research on his self-practice, self-reflection, experiential approach to training, and key theoretical papers on personal practice for therapists and therapist skill development. He is also a therapist on the psilocybin-based prolonged grief trial in Brisbane, and he has had some great news to share about a local clinical trial that just got announced yesterday. So I'm going to throw it straight on over to James to share more on this.
Thank you, Beck. So yesterday there's a pretty exciting announcement that we've got a 3.8 million clinical trial. Sorry, okay, good, thank you very much. The Minister of Health announced that we've been awarded, a group of us at Southern Cross University, 3.8 million for a clinical trial of a stepped care model for disaster-related PTSD in the Northern Rivers. So that's really exciting. It's really exciting, and it's so much a community-developed and supported trial. This, so really every organisation, significant organisation, NGOs, and well, there are many other organisations who we haven't managed to get on board, but a lot of key organisations are on board with this from the North Coast, and our whole basis is developing it as a really community-informed, community-guided clinical trial. Just very quickly, it's a step care model, so that means step one is a community-oriented type intervention, large group intervention, and everyone goes through that first. And we expect a lot of people to actually do so well from that they don't need any further treatment or programs. But step one is an arts-based compassion group program. visual arts, and the alternative to that is a nature-based group compassion program. So everyone goes through that, and then if they are still treatment resistant to the PTSD, then there's a potential of MDMA assisted therapy as the step 2. So that's very exciting, clearly, and just to sort of hold your horses, because by the time it'll be probably late 2025, 2026 before we actually move on to step 2. So that's kind of in the background. But anyway, that's in a nutshell where the clinical trial's up to at this point in time, and we're going right ahead. And there's Ruben in the audience. Do you want to just who's also one of the chief investigators on the trial as well, also at Southern Cross University. Thank you.
Yeah, big congratulations to you, James. I know personally how much work you put into that. So.
And can I just say, Beck was absolutely key to getting the grant in. I met this time last year. I met Beck for the first time, and I thought she's really cool, and I just need somebody else to support this group, to do all the admin work. And so I phoned Beck up a few days later. I said, if you by any chance got any spare time in the next one, she said, yep. And really,
I didn't know what I was getting myself into.
This grant would not have happened without Beck. So thank you, Beck.
Thank you. So, Martin, I'd also like to just throw it over to you to share any of the current and upcoming trials we have in Australia.
Okay, so this is a pretty dynamic space, as anybody who's been watching it would be aware. I'm very happy to say that Australia's flagship clinical trial, the St Vincent's study, St Vincent's Hospital Melbourne study of psilocybin-assisted therapy for the treatment of anxiety and depression associated with terminal illness has completed treatment about 9 months ago, and is just writing up and finishing off its first analysis of results. And I'm very happy to say that the results have been absolutely compelling. I haven't been super close to the analysis for a couple of reasons, because we are funding partners. The organisation that I am running with colleagues is called Psychedelic Research in Science and Medicine. And as a funder of the trial, I can't be too close to the action as it happens. But all that said, the results have been fantastic, and it really was the groundbreaker for psychedelic medical research in Australia. In that intervening time since 2019, when we started that, of course, there's been this amazing flourishing of interest and funding and support for research. So I can say that most of the states in Australia now have clinical psychedelic research either in the pipeline or already underway. I'm personally involved in about 5 studies. I think one thankfully just went off the table, so that helps. Unfortunately, it was going to be a very interesting study, but that's not going to happen. But and of course, we're moving beyond psilocybin into other compounds and beyond MDMA as well. So 5-methoxy-DMT is one compound of interest which may be used for the treatment of depression, and that's going to be conducted at Monash University. Methylone is an analog, a chemical analog of MDMA, and we'll be about to commence a study of methylone with some therapy for PTSD at Swinburne University. Of course, there's an MDMA for PTSD study almost completed at Edith Cowan University in Perth, and there's, as James has mentioned earlier, there's the prolonged grief study. There's a lot going on, so it's really very exciting. And another interesting thing I think to note is that there has been a significant shift beyond philanthropic funding of this psychedelic medical research to the public sector model. And so that has really made a big difference. There's been some funding within and through universities themselves, but of course the funding bodies, particularly the National Health and Medical Research Council, the NHMRC, is now sort of fully behind funding psychedelic medical research. So as I said, I can probably count think I'm up to more than 2 hands number of studies either very close to starting or already underway. It's a very exciting time.
It really is. So Martin, I might stay with you. And how do we move from clinical research into clinical practice, and how might that look?
So that's a particular interest of mine as well as James, because we co-authored an article, going on for 3 years ago now, which was specifically concerned about the challenges, the hurdles that might be encountered in translating from research to community practice or clinical practice more broadly. I think probably the main challenges that we continue to face is a relative shortage of experienced and qualified practitioners or clinicians who can actually administer the psychedelic-assisted therapies. And there's a number of organisations, of course, which have been providing some training for a couple of years, various levels and qualities of training, I have to say, but I think there are others moving into the space, and we're really getting a good idea of how this should be moving ahead. And then, of course, there's the legislative framework or environment, and it's still, unfortunately, a bit of a clunky system that we're having to deal with. We have state-to-state variation in terms of the degree of implementation. Of course, many people would be aware that the TGA rescheduled psilocybin-assisted therapy in the context of psilocybin-assisted therapy specifically for the treatment of depression, and MDMA in the context of MDMA-assisted psychotherapy specifically for the treatment of post-traumatic stress disorder. And so those 2 drugs only were rescheduled from Schedule 9 prohibited substances to Schedule 8 controlled medicines. Now that announcement was made on the 3rd of February last year, and that was implemented on the 1st of July. And I think this is probably the main theme for today's panel is how things have been moving since that time, and perhaps the steps that should take place following this 12 or 9 to 12 months sort of early phase. So I think those are the main challenges. James, would you like to step in, because I think you've also thought quite deeply about all this?
Yeah, I think but a particular challenge is actually not just the training of therapists, but the supervision of therapists. So what we critically lack is, we know if you're learning any therapy, the best way to learn is by practice, but by good supervision as well. And so we absolutely lack that level in Australia of supervisors at this point in time. And that's not an easy thing to generate. So I think that's one issue to point out. The other thing that's going to be, an absolute issue is this only happens through accredited prescribers, which means psychiatrists. At this point in time, the whole system is entirely reliant on psychiatry-approved prescribers. And so that is always going to be a profound limitation, really, on the numbers of people that have access, quite apart from the extraordinary cost.
Do you want to maybe touch on what the cost is for people to get this therapy?
Well, at the moment, people are charging like 25,000, give or take a few thousand, 20 to 30,000.
Yeah, and
for one session?
No, that would be for a course of 2 or 3.
Yeah. And by far the greatest cost is actually therapist time. So the cost of the medication itself is actually a very, very small proportion of that total cost. It's just the fact that clinical psychologists, psychotherapists, and particularly psychologists, of course, are routinely charging in the several $100s an hour. And the current model that's being applied of psychedelic-assisted therapy, which is broadly accepted, but actually being investigated very actively in terms of refining and optimizing some of those and tweaking some of those variables, is that the standard session would be 6 to 8 hours in length, plus a few hours of preparation and several hours of integration after each session. So that amounts in general to about 40 face-to-face hours, according to the current psychedelic-assisted psychotherapy model. And therapists don't come cheap, as it happens. And facilities, of course, are going to be requiring the coverage of their overhead as well. So there's a number of cost factors involved there.
Do we know how many patients have received this treatment in the last almost 12 months?
I think we're up to 3. Yeah. And those treatment courses of treatment are ongoing. So as far as I know, there are 2 patients or clients, I guess, we're working with now in Melbourne who have been treated with MDMA assisted therapy for post-traumatic stress disorder, and I don't know how many of those sessions have been completed so far, but I'm not sure that they're through the whole course of treatment at this stage. And I believe there is at least one in Perth now, again MDMA assisted therapy for PTSD. And actually, maybe 4, because I know of one patient in Melbourne who's been treated with psilocybin assisted therapy for depression as well.
For depression and not treatment-resistant depression. It's a small but significant technical qualification. What's the criteria that a patient needs to meet to get the diagnosis of treatment-resistant depression?
I feel like I'm answering all the questions. I'm sorry at the moment. So, as I understand it, it's still being stipulated by the TGA that it be a second or later course of action or of treatment. In other words, the patient needs to have tried 1 or 2 other treatment modalities or interventions.
Is that usually an SSRI?
It generally would be a pharmacotherapeutic intervention, but it also may involve psychotherapy.
Yeah, it doesn't involve talk therapy.
Correct. No, so to this day, as far as I know, and Symon will be better qualified than I am to actually confirm or refute this, but to this date, I don't believe there are any combination SSRI or other pharmacotherapy plus psychotherapy interventions. Yeah.
Yeah, the ketamine for treatment-resistant depression trial that I worked on a few years ago, the definition was basically that you just had to have failed or not responded to 2 courses of a reasonable dose and reasonable duration of different medications. There wasn't a particular focus on whether those medications more or less were the same in terms of how they worked or not. So, 2 different SSRIs still met the criteria, and whether or not you had any psychotherapy was not part of the definition on that trial of treatment-resistant depression. I think, broadly speaking, that definition comes from a particular study of primarily medication and medication combination strategies for treating depression that was published quite a while ago, that's been the foundation of a lot of the guidelines for antidepressant prescribing. So I don't actually know that, at least in the research settings, you guys might see differently, but certainly the trial I worked on, the person didn't necessarily have to have tried any psychological therapies or even vastly different medications.
In clinical practice, why is it that it has to be done in a in a hospital setting?
Primarily safety. So, it's a big difference when you want to pass the legislations and cross all these barriers. There's a set of assumptions that people will be safe. So they want the medical treatment centers to be able to provide constant blood pressure monitoring and any type of, and as some of you might be aware, we did have an unfortunate couple of cases here that didn't end well in the underground scene. So for the authorities, it's a very concerning issue. I just want to say that with all these things, at the end of the day, if we are able to kind of, because I often get asked these questions about underground versus clinical, about cost versus that. And all to all, I just want to know that it has been a long time coming. The prohibition on human beings not to be able to engage, the exploration of their own consciousness. The fact that just this morning I was stopped on the road for these ridiculous drug testings that are inaccurate and lots to be said about that. The legalities of it all, that we are now facing, once again, the barriers are breaking down. It's been a few decades in the making. And it is important that we all unite rather than argue which way is better. Because the authorities are not going to let this one go easy. And they want to make sure that people are safe. So they're putting all this stuff, and I don't even look at it as that we're doing research, we're doing therapy, we're doing whatever we can to promote the idea that people will have the freedom to engage these type of practices and hopefully bring about a change. It has been global, not just in Australia. There's been a global banning on us being able to do so. These compounds have very promising future, especially with the times we're in. Separation, division, hatred, conflicts everywhere. At least that's what we're being shown and told. So we have to find a way to go back to unity and love, I think. And only by the barriers of our own minds breaking down can we achieve that.
Just to be clear, in Queensland and Victoria, and I think in WA, psychedelic-assisted therapy is available in clinics. But in New South Wales, the legislation is currently, and it's, a ridiculous state-based system, that psychedelic-assisted therapy is only available in private hospitals, only in private hospitals. I think this will change because I think many of us have written to the New South Wales government to say this is inappropriate. And I think there is quite a lot of pressure there to change, and I believe they're going to look at it again in August. So if you're concerned about this, I would recommend letters to Minister Jackson, who's the Minister for the North Coast and the Minister for Mental Health, and to Park, what's his name? Ryan Park, who's the Minister of Health in New South Wales. And I think it will change, but a bit of pressure would help.
Just to add to what James was saying, actually, that there's been a reasonable amount of work in the clinical research field to try and sort of work out the best, the best sweet spot between a clinically safe and supportive environment. In other words, if there is an ab reaction for whatever reason, we take a lot of steps, the best we possibly can, to prevent or avoid those reactions by excluding people who might have cardiovascular sort of issues, for example. But finding the sweet spot between the clinical environment and then the environment that most people in the underground and most people sort of in the general community would regard as much more conducive for a positive psychedelic experience. And so if we can find that happy combination, I think there's every chance that things can move forward quite quickly, but that also will involve significant investment in infrastructure in terms of purpose-built and designed facilities. And we're seeing that play at the moment in terms of some of the commercial clinics, a couple of the commercial clinics starting up for psychedelic-assisted therapy around Australia. There are various interpretations of what constitutes a conducive environment, and so we see some which have a nice sort of view outdoors. Some of them are much more cocoon-like, so I think there's scope for interpretation. It'll be interesting to see how things play.
Also important, during these therapies, many times people are asked to go in with blindfolds. So the environment, indeed, you want to have a backyard and you want to have some nice settings, but the essence of this is to go in. And again, even in the training that James organized and is pushing this forward, training psychotherapists to be able to provide this type of therapy, it is often an issue that is coming up, that the medical setting can be quite, let's just say, I don't know what, just not as ideal if you are, especially if you're using the psilocybin. And nature and the beauty is very important. The aesthetics of it all is very important. So people are doing whatever they can. They're making the room look nice, and they're hoping there's a backyard or a window. But at this stage, we're very, very limited to what we can do, and hoping to change that too.
Nice. Micha, I'll stick with you. You are, in my opinion, one of Australia's leading or most experienced practitioners in psychedelic integration. And I believe that you've been studying your PhD in psychedelic sciences, where you're looking at how to integrate the above ground industry with the underground. What can authorised practitioners learn from the underground practitioners in relation to facilitation and integration?
I find that this realm is about self-work. So there's underground practitioners that I know I've referred people to, and I would trust them with my life. And I think they're doing amazing work. And they have been doing it in the shadows, and they have been taking great risk, and they've been doing it for many years. So I think they learned the hard way. They learned through trial and error, and as you know, exploring these states of consciousness can induce a lot of risks too, to human psyche. So for me, it's not really, if you're playing the medical game, yes, you want to have, you cannot play the medical game without these type of papers on the wall. But ultimately, this work is boiling down to people's own exploration, in my humble opinion, own exploration of that realm and own work on themselves, to be able to hold space even for that kind of journey prolonged over 8 hours. And the clinical models too, by the way, during the sessions they're encouraging a lot of introverted work and as less interference from the therapist as possible. It's not like you're sitting there with a white coat and asking questions about psychosis. You're not.
Nice. A few weeks ago, James, you and I were sitting down at breakfast, and you shared with me an article about Roland Griffiths and his research into psilocybin and mystical experiences. And you asked me which modality I thought best treated depression. And whilst I personally believe that psilocybin obviously has its place and it's excellent with end of life, end of life anxiety, and sort of giving you a bit of a peek behind the curtain there. But for the treatment of depression, I sometimes think that the experience can be more difficult to integrate or interpret a hallucinogenic experience, whereas you don't so much have that problem with MDMA assisted therapy. So do you think that the TGA has overlooked MDMA assisted therapy for the treatment of depression?
It's a really interesting question. What's happened in practice is that all the MDMA research until very, very recently has been sponsored by MAPS, the American organization, who have been trying to get through all the FDA American hurdles in order to get MDMA legalized, basically, for clinical use. So they focused entirely on PTSD, single-mindedly. In practice, of course, many people with PTSD have depression as well, and actually MDMA does look pretty good for depression, and may indeed, as you're saying, Beck, be kind of a little easier to integrate. But up till now, nobody has done a depression without PTSD trial with MDMA. So all the research, which sort of, initially came out of Johns Hopkins University in America and Imperial College in London, which has been on psilocybin, has been for treatment-resistant depression. So the answer is we simply don't know at this point, but I think it's something that needs looking at.
some people in this space might be familiar with the concept of the hippie flip. The hippie flip being a combination of MDMA and psilocybin specifically. And many people who have some experience in that space would attest that the MDMA can definitely take the edge off what otherwise could be quite an anxiety-inducing and quite a challenging, particularly the induction or the initiation of the psilocybin experience. But interestingly enough, I think it could be worth exploring that particular combination for just the reasons you were alluding to and referring to.
Yeah, and I think fairly recently there was a survey, like a population survey study, just a convenience sample of people in the broader community who were planning to take psilocybin with MDMA, and they sort of reviewed whether that did actually have those effects in terms of reducing some of the possible negative outcomes and reducing some of the anxiety associated with the psilocybin. And I think that was pretty promising in terms of an initial indication that it is something that warrants further exploration, and that hopefully sets the path for then putting together more targeted, clinical research studies that actually look at that combination. And I wonder if it would be possible then to end up possibly using like slightly lower doses of the psilocybin, because what is used in clinical trials is a reasonable dose, and maybe with the MDMA on board you need less. I also think with like the core beliefs that are often present in depression, that often it is around having a negative view of yourself and a negative view of others, and often with trauma in the background, difficulties with trusting other people and with feeling worthwhile and feeling lovable, and that you could be have some inherent value, that often MDMA just tends to create that sense of self-compassion and self-empathy. And I think where that's then guided with some therapeutic support, you can really optimize that experience and hopefully carry some of those emotions forward after the experience is over, to hold on to that idea that in that moment I felt like I was lovable, and in that moment I felt like I was worthwhile, and in that moment I felt like I could trust other people. And if that's one of the only times you've ever had those emotions in your life, especially if you do have significant trauma in the past that's made it really hard to feel that way, I think that profound sense can be really overwhelming, but it is then possible to actually carry that forward, because at least you've always got that reference point. You can go, no, there has actually been a time where I've felt that way about myself and I felt that way about other people, so why can't I feel that way the rest of the time as well? And that can sort of be worked on and built up. So I think MDMA assisted therapy for depression could be really useful in that regard. Also, just the capacity to form a quicker therapeutic alliance with the person that might be in the room with you doing some of the talk therapy during the experience, or before or after the experience, even if it's not happening under the influence. Sometimes that therapeutic alliance can take quite a long time to form when you're just doing therapy without the substances involved. If you can sort of speed up that process a little bit, I think that makes it a lot more likely that the therapy you might have after the medicine will also be more effective. You've got that relationship and that trust in the therapist that's easier to then make the rest of the therapy work.
Symon, I hear that there's some concern. Sorry, did you want to say something else, Micha?
Just to build up on what Symon said, there's so much hype, especially in mainstream, less so in people who are very experienced in the psychedelic realm, that somehow these compounds represent a magical cure, and you just have one session and you're all enlightened and cured. And the reality of anyone who has experienced that over a few years is that it's like a Cinderella story. Once the music stops, you're back to your old annoying donkey self, and there's a lot to deal with. And so not to also bring down the fact that it's kind of shining the light on where you can go and what is that momentary experience you talk about, where your sense of self dissolves. That's a powerful thing for someone who is trapped in a very negative loop in their relationship with their sense of self. At least it provides hope that not all is as we thought it is.
I sometimes say that if it was down to the pill, then the whole of the North Coast practically would be enlightened. It's more than that, clearly.
So Symon, I hear that there's some concern around microdosing psilocybin long term. Can you elaborate a little more on that and what that health concern is?
Yeah, it's an interesting question, and I think there's a lot of people now that are microdosing in the community. There's not heaps of high quality evidence that I'm aware of to back that up yet. I wonder about the sort of pharmacology of that approach, but I won't sort of dive too much into that at the moment. I think anyone that's tried to take mushrooms 2 days in a row would understand that they generally don't do nearly as much the second day. The receptors there, they obviously develop some tolerance fairly quickly. Whether that impacts the neuroplastogenic effects of the psilocybin, so like its ability to help the brain form new pathways more easily, which is part of its sort of suggested therapeutic effect. I don't know whether that then changes if you've changed the receptors by taking it multiple days in a row. But there's also concerns around the possibility of valvular heart disease with 5-HT2B activation. There are some other substances that are known to cause that as a side effect via that mechanism, and I don't know that there's been enough research into whether psilocybin might share that possibility if taken consistently and regularly long term, and whether that would have to be a dose effect, you know, that maybe very, very low doses, that's not so much of a risk. Maybe it's not a risk at all, because different drugs can bind to the same receptor but have very, very different effects on the cell just because of the way the receptor is affected by the substance. So I think it's something that's just worth bearing in mind, that there isn't a lot of evidence around safety of microdosing long term yet. There are some theoretical concerns that I think need to be borne out a little bit more in the research, be that, you know, theoretical research or maybe animal models. And that also, you know, personally, I'm not sure the evidence is there yet around the potential effectiveness of microdosing the way that a lot of people do, which does tend to be pretty consistent. Some people might do it for 3 or 4 days in a row and then have a couple of days off, but it's all just anecdotal sort of approaches at this stage. Like there's protocols that people suggest, but I don't think there's any clear evidence to sort of support any one particular approach to a microdosing protocol at this point in time. There's some promising early research that, you know, microdosing can improve can change some of the same biochemical markers that you look at to know whether it's likely to be helping the brain form new connections more easily. But it's, I think, very early stage research still with microdosing, at least from what I'm aware of.
As with SSRIs, I guess I'm not convinced that microdosing psilocybin or taking SSRI should be used long term anyway. And, you know, I kind of feel like you should be taking them until you've made your significant changes in your life. Why is there so much conservatism and concern around researching or researching further or using a natural product that is certainly easily found around these areas when so many SSRIs and pharmaceutical products in general, but SSRIs in this case, come with severe health warnings such as suicide, suicidal ideation, akathisia-induced impulsivity. I don't believe that everyone's quite getting their, like, in full informed consent. So why are we not doing, or are there any clinical trials happening, or why are we not considering this as a potential treatment for instead of SSRIs?
I mean, I think that the research that's going on now will be the foundation for looking at it as an alternative to SSRIs, but I think there was so much stigma and, you know, the public perception within regulatory bodies around psychedelics that to start by saying we're just going to try this as a first-line treatment, I think would have been a really, really difficult thing to get across the line. So I think they did have to start somewhere, and picking treatment-resistant depression, which, you know, depending on how you look at it, can be anyone up to like 40% of diagnoses. So it is still a huge population group, and it's still a huge area of need. Those people who respond really, really well to SSRIs respond well to SSRIs. And I think part of the problem with SSRIs and their side effects and their lack of effectiveness is who they're being given to as well, that there is a much broader definition of depression these days, and that often practitioners and people will be requesting medication as the solution rather than wanting to do therapy, and I often have really difficult discussions with people about why I don't want to and don't think an SSRI would be the right choice for them. And I'm always surprised by the response to that, because a lot of times people seem to think that that's me saying you're not sick enough to need an SSRI, when in fact what I'm trying to say is I understand you're struggling, but I don't think an SSRI is going to help. I think what will help is going and doing some sort of psychotherapy. But there's quite a range of people's responses to that discussion. I think we live in a society where a lot of people do want to take a pill and that will make things better. Yeah, and you know, the psychological work is harder than taking a pill. SSRIs also without psychotherapy aren't going to work as well for that many people. There's certain types of depression where the medication on its own does tend to do a very good job, but there's always still some underlying stuff that needs to be worked out. And SSRIs as well, we understand now, probably one of the main reasons they do work for depression is by increasing the brain's ability to form those new connections. It probably has much less to do with serotonin levels that have never been consistently associated with depression anyway. So that was like the old school of thought on why they worked. I think that has moved on. And psychedelics do that, but much more potently than SSRIs do. So I think... and the other reason, I suppose, is that at the moment there is that whole cost and therapeutic framework and like the resource aspect of giving psychedelic therapies that for most people at this stage is just inaccessible. And SSRIs are cheap, they're readily available. Psychological therapies, you know, generally speaking, when people are doing them, they're not doing them as frequently as they would be through a course of psychedelic assisted therapy, so the cost is therefore a little bit lower. So I think it's just, you know, it'd have to be a starting point somewhere. Picking an area of need like treatment-resistant depression was an easier way to get things through those initial regulatory hurdles. But hopefully over time the evidence of safety builds up, the evidence of effectiveness builds up, and then you can start more easily investigating them for other indications and maybe more for first-line treatments and hopefully potentially even towards health maintenance and illness prevention, rather than waiting until people are unwell or really, really unwell and then offering them a treatment that might have actually helped stop them get there in the first place.
I think one thing that in the several years of advocacy that led up to the rescheduling by the TGA, there was something of a line that we've got all the answers. We know all we need to do is start employing psychedelic assisted psychotherapy and everybody will be cured, mate, you know. And so it's sort of my feeling is that we're just at the very beginning of the process of actually working out how things work, how best to utilize them, how best in particular, and I'm not an expert in this area, but I know enough about it now to realize that post-treatment support of anybody, whether it's on SSRIs or psychedelic-assisted therapies or other modalities, can result in very, very significant improvements to people who are actually not particularly well prepared, unfortunately, psychologically, to have that, to experience that dramatic improvement. And so, unless there can be a significant shift in somebody's whole sort of life context in certain cases, not all by any means, then I think it's important to be prepared to provide a lot more support than seems to have been suggested or agreed upon as the optimal treatment approach.
I think it's also worth saying there's a paper that's just come out very recently that I think is really important, saying that every single new therapy for depression or anything else, it starts off at fantastic results. So all the initial CBT trials, all the initial SSRI trials, interpersonal therapy, whatever you name, fantastic results. Because for various factors, obviously, you know, the researchers are absolute enthusiasts, get the best people, the who gets into the trials are so carefully selected. That is so much the case with psychedelics at the moment. These people, you know, 1 in 10 or less get into clinical trials who apply. And they are highly, highly selected because, of course, the researchers want to get the best results. So, you know, so people with comorbid disorders, so they have, you know, PTSD as well as depression, do not get into the depression trial. So what you're going to see is that the results are, as we get more real world, will come back to, norm. Hopefully they'll be better than, and I think we can say at the moment that psychedelic assisted therapy looks promising for specific, there are only very few disorders in inverted commas that have been tried, that we've had full trials at the moment. But that's the situation right now, and I think the more we look at it, the more we recognize it's not the pill. It is psychedelic assisted therapy, and it's all about integration. And even the clinical trials at the moment are, because they've sort of tried to be restricted in terms of how long integration goes on for, it's really not optimal at all. Integration should really be happening over the next year or so, not over like 4 weeks or 8 weeks. It's where most integration stops on clinical trials. So I think we're going to see a very different picture emerging over the next few years. And in some ways it'll be disappointing, but in many ways it'll be a lot more realistic, and we'll really know what we're doing.
I also just sort of want to point out that I think for a lot of people who are coming at this from a psychedelic community perspective, and they hear people working in the clinical fields talking about the need for all of this careful containment and these sort of professional psychological supports as a framework for getting the benefit out of these substances, that it often sounds a little bit off-putting, because a lot of people have had their own experiences and they feel like they've got significant benefit out of that. They see friends taking them and not having really difficult or really bad outcomes, even if they have had a difficult experience. And I think it's really important to draw the distinction there as well between clinical populations who have very different needs to otherwise healthy, generally psychologically well individuals, because I think the level of risk is very, very different, and I think the level of support required to use them in those populations is also very, very different. I think it's a really important distinction to draw. That's not to say that I don't think a lot of people using them in the community would not also get more benefit from them if they had some framework around it and potentially some integration stuff, be that peer-based or professionally led, depending on what their need and what their intention from the experience was. But I think from my perspective, it's really important to differentiate between those clinical populations and the frameworks required there versus the broader population who are maybe using these substances for personal exploration or dealing with maybe minor struggles that they're having when they're otherwise reasonably well, psychologically speaking.
Yeah, cool. So before we go to audience questions, I wanted to veer away from Australia for a moment and ask your opinions on the MAID laws, so the medical assistance in dying laws in Canada and in Europe, and are being offered to people who are non-terminal and people who in some cases have mental health diagnoses. So a few questions here that maybe you guys can sort of just have a think about and answer. Are these people who are being approved on mental health grounds potentially just deprived of psychedelic or MDMA-assisted therapy? Which do you think is more likely to solve our global mental health crisis? I guess possibly keeping in mind that I'm sure MAID is a much cheaper option, unfortunately. And do you think that Australia would ever approve of mental health as a reason to give medical assistance in dying? They're big questions.
It's like the voluntary assisted dying laws in New South Wales have come into effect, and there's a big regulatory framework around that now, that we are receiving some teaching and training about how to navigate those systems. I think we're a very, very, very long way in Australia from giving voluntary assisted dying to people with serious mental health concerns. And in fact, even in terminally ill people, it's really strict what the criteria are, and you need to have capacity to give informed consent right up to the time that you are actually administering yourself or being administered the substance that is going to take your life. It's a really hard argument to make that someone with a really severe mental health issue would have that informed consent, or that capacity to give that informed consent, which isn't to say that they don't necessarily, but it's a much harder discussion. So I think we're a long way from that. I think that's a good thing. I think that's a really complex issue, and I'm aware in Canada and in the Netherlands that there have been cases of what are called severe personality disorders, for better or worse, whatever that term may mean, who have actually accessed medically assisted dying, and I think eating disorders as well. At this point in time, I would personally think that anyone who is looking towards medically assisted dying for a mental health condition should, on compassionate grounds, be at least offered the opportunity to try one of the psychedelic assisted therapeutic modalities, because I think it does have a lot of promise and a lot of potential, and I think you're seeing responses in some individuals who've been depressed, or unwell for a very, 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 very long time, who don't see the light at the end of the tunnel. I saw this working in the ketamine trial that I worked on, that people who'd been depressed for 30 years plus suddenly felt better. Unfortunately, with ketamine, that didn't persist. They often felt worse again after a couple of days. That's not what was seen in the early trials of psilocybin for treatment-resistant depression, though, where you were seeing, again, bearing in mind that it's very careful patient selection and very careful sort of therapeutic framework, but the benefits persisted for quite a long time, like months to a year. And I think that in that case, we know that there is the possibility that there are treatments that might be now available that could actually give people that light and that hope. And possibly make it more likely, again, that the other therapies that they've tried before that didn't work so well for them may then actually work and work better. So again, it's not the pill and it's not the drug that's going to fix them, but it might actually mean that some of the therapies they'd already tried will then be able to work because of both the experience they've had on the substance and the biological effect on the substance, on the brain's ability to form those new pathways that underlie your patterns of thinking and your patterns of behaviour that underlie your mental health condition. So yeah, in short, I think those people should at least be being offered. I know that I think in America now there are some places where they're looking at offering it on compassionate grounds for people with particular terminal illnesses. I think Canada, they're doing the same. I think those are really positive steps, and hopefully that is something that can sort of continue to expand as well.
Cool.
I don't know if offered is the word, maybe even conditioned, because I'm thinking what a slippery slope that is, right? Euthanasia in and of itself is a beautiful thing. It's a value that democratic societies want to have, that people are able to choose if they suffer too much, if they're too unwell, and so forth. But I have that angle too, that a couple of decades ago I was contracted and trained by Queensland government to provide suicide prevention programs, primarily for young people. And I've done that for 3 or 4 years, and it was really, really hard, because what do you do when a young person is engulfed in depression and sees no light, and you have all the kind of experience and wisdom that comes with the years to say, yeah, this is a chapter of your life, not necessarily the rest of your life. And if we then decide to put a few criteria on a piece of paper and say, yeah, if you tick these boxes, you can actually choose euthanasia at the age of 18 because of depression, I find that to be very complex and dangerous. And the other thing I want to say is that this discussion involves a broader political discussion. Like, really, you need a few weeks for that stuff. And what's happening in the world, in my view, is some form of a neoliberalist move in which they are creating crises all the time. Our beloved narcissistic, sociopathic, neoliberalist leaders around the world. And as such, they have created an assault on humanity. And we are confronted with this on all fronts, including our sense of self. So here we are, we're offering a lifestyle that causes a lot of suffering. We then offer medications that sometimes enhance the suffering, and now we're offering the solution, which is to choose to die. And if we choose to explore our consciousness in some other ways, it's illegal. How is that even making sense? And I think we should fight for it. We should not take it as is.
Either illegal or very, very expensive. Anyone else choose to? No? All right. So yeah, we will go over to the audience. Is there anyone out there that does have a question? Yeah.
Just speak up, shout out. Shout out.
I'll shout out. Are you an MDMA practitioner in America? Is that yourself that had that on the biography? Yeah.
Yeah, so I was just asked if I was an MDMA practitioner in America, and yes, I have received the training, and so I have done it, but I do not do it here in Australia.
I see.
It is highly illegal.
I'm really fascinated that there's a whole practitioner protocol about that. I'm a mental health nurse myself, so I'm used to the prescription of psychiatric medications and giving them to patients and stuff. And I find the highly, like it's so interesting to think about the psychological, the psychedelic therapy that's being offered within this context of like constant monitoring and then integration afterwards. You know, in no other medication is that there, you know, like I've seen a lot of very strong medications just prescribed and we don't really even know if they took them or not, or they took them according to instructions. It's just such an enormous gap. So I find that interesting. I'm really fascinated by a lot of things that you're saying, but that particularly strikes me. Yeah.
I think that's an excellent point you're making. That I guess the response is that the clinical researchers who obviously have a view to translating to clinical practice and are very supportive, intrinsically supportive of these approaches, have been exercising what we might regard as an excess, but certainly an abundance of caution in terms of really establishing the safe framework, the safe container for these experiences. That may or may not change. It may change quickly or slowly. We don't really know at this stage, but it certainly has to be reiterated and reinforced that the TGA's guidelines at the moment absolutely specify that they can only be taken under, psychedelics can only be administered and taken under supervision. And given that, although there's been a general sort of maybe a little bit of hype and hysteria about the positive outcomes, there's also an increasing part of the conversation about the potential for negative outcomes and longer term negative outcomes. And so I think that's really incumbent on us. It's our responsibility as clinicians and researchers to ensure that the safest possible framework can be put in place. It might seem onerous, but I think it's probably the best way to go at this stage anyway. And it's also, I think, it's an abrogation of responsibility, if that's the right word, for people who might be working outside the current legal framework not to exercise the same duty of care.
I don't think psychedelics can be compared to any other currently used psychiatric medication. I mean, yeah, we give out a lot of very strong drugs, but the experiential nature is just chalk and cheese, like completely incomparable. So I think that there is that need for that framework for these clinical populations, or at least for some framework, be that necessarily a medical model or whatever else. But I think there is a need for that framework to exist, and I just think the experience of these substances is so different to any of the other medications that are currently used. I don't think they can be readily compared in that regard.
Absolutely. I'm sure it's very helpful for the patient wanting to take something, to have that companionship and that chance to think about it more. I'm sure that's very helpful. I'm just really interested.
Yeah, question up the back.
Shout out.
The question was, is it critical or obligatory essentially for participants in clinical trials to be drug naive or psychedelic naive? I can say no, not necessarily. It really depends on the specific trial. Certainly in studies of psychedelics in healthy populations, which were generally the phase 1 studies to first to check safety and then what they call pharmacokinetics, so the way the drugs behave in a human body. Generally, it was preferred that participants be psychedelic experienced, because it was thought that if they had some sense of what they were getting themselves into, in fact, they would be in a better position to give fully informed consent to participate in the study, and that the psychological effects of those would be sort of somewhat anticipated. And because the psychological effects weren't the main focus of the research, then it didn't really matter whether they had expectations or not. That has changed now as we've moved into phase 2 and onto phase 3 studies. These phase 2 and 3 studies are in what we call clinical populations, so they're treatments for a specific condition, usually a mental health condition such as depression or anxiety or PTSD, or even though PTSD, it's debatable whether that's a condition. But all that said, then generally it's preferred that the participants be psychedelic naive, because otherwise expectation or expectancy can become a confounding factor and a significant challenge to the effective conduct of the research. Now that we've had books such as How to Change Your Mind and a lot of media exposure of psychedelic-assisted therapies, that has also generated a lot of expectation on the part of participants. So in some ways it's almost impossible for anybody to, just as it's almost impossible for people to join be a part of a jury trying the former president of the USA for certain misdemeanors and naughtiness, it's also almost impossible to find people who don't have some sort of expectation of psychedelics and psychedelic-assisted therapies. So, good question. It's complicated.
Can I just come in on that? That will not be an expectation in the North Coast. Otherwise, we might have quite a small trial. But, however, having said that, it will be an expectation, and this will be part of the protocol, that there will have been a significant period since the last time that you took a psychedelic. And I'm not quite sure whether it'll be like 3 months or 6 months, but it'll be of that kind of nature. The other thing I just want to say while I've got the microphone is that we do have a flyer here for anybody who'd like to just keep in touch with the trial. We're not, we haven't gone through ethics yet. We're not taking anyone in at this point in time, but we have a email address. So if you'd like to, I've got flyers here, and Judy, who's there with her hand up, has flyers. So if you'd like to get hold of one, we are here, and we'll be at the back of the tent after this.
Awesome. Thank you so much, guys. That's actually all we have time for today. But thank you again, gentlemen. I really appreciate your time, as always. All right. Thanks.